what has preceded us and what is to come. At Princeton University, as well as communities across the country, we're trying to engender conversations about the driving forces of 2020 and what I would imagine will continue to be driving forces in 2021. We're seeking to highlight problems and challenges, real life issues that we're all facing, but also solutions and approaches so we can create paths to a new reality. And I'm looking forward to the next installment in this series focused on education. So today, to paraphrase Dr. Chris Pernell, who's one of our speakers, we're going to examine COVID-19 through a health, equity, and racial justice lens. For a conversation like this, we're going to start with data points. So data. What do we have just this week? Vaccines. We saw Vice President Pence receive his vaccine shot. We've seen that play out on our screen from scenes across the country. Alongside that, we have conversations regarding race and health. Just today in Inside Higher Ed, Princeton alumna Deborah St. Fard, MD, currently at the University of Colorado School of Medicine, wrote about the intersection of burnout, COVID, and systemic racism. And it's heartening to see that as tough as a topic as this is, that it is getting airtime and column space across a number of channels. Another unfortunate data point, over 300,000 fellow Americans have lost their lives to COVID. It has touched all of us in many ways, some very close to home, which our speakers will talk about. And while vaccines we're seeing scenes of vaccines being administered on our screens, it's going to take some time for the vaccines to be distributed and administered. I have a national security background. If we were waging a battle against a foreign enemy where over 300,000 Americans lost their lives, we would rally on a national scale. We would make sacrifices as we rarely do. We would unite as a country. There would be debate and protest because this is America. But we would rally in a way that unfortunately we have not seen as much. We've seen a country divided against itself. We've seen existing fissures exposed and exacerbated. We had a panel on the elections the day after Election Day with Eddie Glad Jr., Kianga Yamahata Taylor, Ali Valenzuela, and others. And it was fully acknowledged race was not just a component of our society debate and the election, but the component. We see demographic disparities, unemployment, rising food scarcity, and a looming eviction crisis, which fellow researchers at Princeton are delving into through the Eviction Lab. Why is this? Is it because so many of the victims are from historically marginalized communities? That's just one question among many that is certainly on my mind, and I think many of yours. And where are the opportunities to fix these issues systemically at this time of crisis? So with us to unpack not only the disparities, but also share models and solutions are our panelists. I'll start with Dr. Chris Pernell, who is focused on health justice, community-based advocacy, and total population health promotion and disease prevention throughout her career. After Princeton, she received her medical degree at Duke University School of Medicine, and an executive master of public health and health services management from the Columbia Mailman School of Public Health. She is currently at University Hospital as the Chief Strategic Integration and Health Equity Officer. University Hospital is New Jersey's only public hospital and the largest provider of healthcare for uninsured people. Next, we have Dr. Owen Garrick, President and Chief Executive Officer of Bridge Clinical Research. At Bridge Clinical, Dr. Garrett has responsibility for the clinical trials, research analytics, health services research, and healthcare communications, close to my heart, business units. Bridge Clinical is a global private equity-backed contract research and health communications firm focused on drug development, scientific advancement, and patient engagement. After Princeton, Dr. Garrett received his MD from Yale School of Medicine and his MBA from Wharton School of Business. Thank you for joining us. And last but not least, we have Dr. Yolandra Gomez-Toya, a member of the Jicarilla Apache Nation in northern New Mexico. After Princeton, she received a Master's of Public Health from the University of California at Berkeley in 1991, received her medical degree and completed her pediatric residency from the University of New Mexico School of Medicine. Dr. Gomez-Toya is one of fewer than 300 Native American pediatricians in this country. currently working full-time in private practice in Rio Rancho, New Mexico, and also pediatric consultant at the Pueblo of James Clinic, pardon the pause there, where you practice, where you specialize in developmental pediatrics. In addition, she is assistant professor of the University of New Mexico School of Medicine at the University of New Mexico School of Medicine, where she teaches and supervises medical students primarily in primary care and rural medicine. As you can see, all of our panelists are well qualified, deeply experienced, and we're grateful for their time today. And go Tigers, thank you for beginning your academic careers at Princeton University. So we're going to start off with a question for each of you. And if it's all right, I'll go in the order that I did the introductions for each of you. According to a myriad of reports from federal agencies like the CDC and a range of news outlets, African Americans, Native Americans, Latinx, Hispanic people are dying at rates much greater than their population share. Long-standing systemic health and social inequities have put many from racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19. Would each of you talk about some of the systemic health and social inequities, their connection to long-standing historic systemic inequities, discrimination and racism, and some of the efforts, and this I think will be a theme throughout the next hour, that you've been leading to address them. Dr. Chris Pernell, we're going to start with you, and I know this hits close to home for you. You lost your father. You have all of our sympathies.
Thank you.
Do you mind telling us a little bit about that?
Sure. So as you can imagine, I've been talking about this quite a bit, right? And reflecting on how best to encapsulate and create a public narrative around what we're experiencing. We keep hearing, and we know this is an unprecedented public health crisis. It is catastrophic on a global scale. It has disproportionately impacted Black and Brown lives. But I can best say that what we're actually seeing is the collision of two pandemics. And I've heard that described by others, and I'd like to put a finer point on it and to say we're seeing a collision of the fast pandemic and a slow pandemic. That fast pandemic being this novel infectious agent which seemed to have exploded out of nowhere onto the global scene back as far as a year ago in December, speculation, maybe cases even in November, first confirmed laboratory diagnosis in the United States in January 2020, but it's been here for about a year, right? This fast pandemic that has wreaked havoc. There was a lot that we did not know about transmission, a lot that we did not know and still do not know about treatment, although we are gaining ground daily. And it capsized a lot of where we were as a nation. But then there's that slow pandemic that's collided with this fast pandemic. And that slow pandemic is systemic racism. And systemic racism has been with us for over 400 years. It's in the root of our soil. It is the collision course. It is the collision course of that fast and slow pandemic of coronavirus and systemic racism that has borne disproportionate impact on Black and Brown communities. And we know back in the spring that the pandemic had at its epicenter New York, New Jersey, had as its epicenter Newark, New Jersey. I like to describe to people that the epicenter landed on me personally. While working in one hospital, I lost my father in another hospital only 4 miles away. My father, a Black man who endured the Jim Crow South, a self-taught research scientist who started at Bell Labs cutting grass, but ascended the research throne to become a member of technical staff, couldn't escape the pandemic, couldn't escape the comorbidities that he had that landed him in the hospital for something else and got exposed in the hospital and died. I also have a sister that was impacted by coronavirus. And it's important to point that out because she, a breast cancer survivor, worked in a large retail chain and often in the beginning of the pandemic, limited access to PPE. So that talks about how Blacks and Browns predominate certain work industries or work sectors. And too often those work industries or work sectors are lower paying jobs, and those lower paying jobs have less income protections. So the ability to work from home, to work remotely, and oftentimes had less PPE. My sister is what we call a long hauler. In some 8 months months later, is still struggling to recover, showing some progress off of her supplemental oxygen finally, but not yet back at work. And then 2 weeks ago, I lose my cousin. I lose my cousin to coronavirus complications. My cousin is an essential worker. My cousin is a postal worker. So constantly in the public, exposed. And I think it's so important to say that, because how racism has operated as a pre-existing condition for coronavirus is in exposure and vulnerability, whether those exposures are in the living conditions, right? The legacy of residential racial segregation and redlining, whether those exposures are in the work environments, the types of sectors and industries that Black and Brown people overpopulate, or whether that vulnerability is because of being saddled with chronic health conditions. And those chronic health conditions we know are very much rooted in those social determinants of health, those non-medical, non-clinical determinants, where you live, where you work, where you play, where you worship, where you learn, where you were born, and how those things determine life exposures and hence determine health outcomes. So when I say that there was a collision of two pandemics, that's what I'm describing. And when I say that racism was very much a pre-existing condition, that's what I'm describing, because racism predetermined a lot of those vulnerabilities and a lot of those inherent exposures because of those vulnerabilities. So I think I'll just start with that.
Owen.
So, and Chris, thank you for that. So the work I do is in this area of clinical trials. So I'm a medical researcher, and as a company, we manage clinical trials for drug companies. And Ben, to get to your point around issues of race, historically, there's been an underrepresentation of people of color in clinical trials. And so what does that mean? The punchline is you can't completely be sure that new drugs and new therapies work in individuals if they are not first tested and studied. Right, so there's a component of this, whether you call it health equity or health disparities, there's a component of that which is a function of these drugs, potential new therapies not being tested in individuals, and frankly, individuals of color not being a focus of research, right? So there would be two things we would want to do, right? We would want to ask better research questions, right? Because we are interacting with these communities and understanding what their issues really are. And then secondly, in terms of the work I do, we would, for existing or for drugs that we are thinking about bringing to market, we would have them involved. And if you look at coronavirus, as you mentioned, and everyone knows, there's this overburden from a disease perspective of Blacks, Hispanics, Native Americans. And so what that should mean is there should be an oversampling, and that's a fancy research word for meaning there should be more people from those backgrounds in a clinical trial. So your coronavirus studies that we've been hearing about should have maybe half of the population be Black, Hispanic, and Native American, right? Compared to where we're underrepresented. We don't even get to the numbers we are in the population, right? So that shows you that there's one overrepresentation. And then you have to begin to think, well, will these vaccines work in the populations that aren't necessarily represented to the same degree? So those are some of the things that we worked through. Now, we weren't as a company involved with any of the vaccine studies, but we were involved with a COVID pneumonia study that focused just on minority populations. So a little over 400 subjects earlier in the year. Blacks, Hispanics, and Native Americans represented about 85% of the population in the study, right? So we show that it can be done. There are these issues of trusting research and trusting the healthcare workforce generally, but we show that it can be done. It was pretty straightforward. There's a famous bank robber, Willie Sutton. He robbed banks because that's where the money was, right? And so we, as a research enterprise, go to places and individuals like Dr. Pernell and Dr. Toya that have the trusted relationships with their community. And those are the physicians and research scientists that we went to in this Impacta study and got this overrepresentation because their patients of color trusted them naturally. And I'm sure we'll talk about some of the reasons why that happens later on. So those are some things that we think through. I mean, that doesn't sound like rocket science, right? Because it's not. right? And many of us know and can identify, other Asian spokespersons, right? Other Native American clinicians, other Black clinicians and scientists, because we just have those natural networks that, let's say, our mainstream or the rest of our American friends and colleagues don't naturally have. So those are an issue, a problem, and I think a way of getting to potential solution. Real life here in this COVID environment, right? The drug we studied was actually used for rheumatoid arthritis, and the drug worked on managing inflammation and the inflammatory process. And I'll spare you a lot of the microbiology and the biology, but there was a sense that you can also reduce this inflammatory process, this leukotriene storm in the lungs, because that's what kills you, right? That's what's killing most individuals that get COVID. They have this acute respiratory syndrome or disease. They get placed on a vent and basically can't breathe, right? And so if you can reduce, prevent that progression, and there was some great evidence in these minority populations that you can then decrease the mortality. So those are some of the things we think through. What are the real problems? Let's figure out real solutions, in this environment that isn't, or at least in this country that historically in many ways has not been as friendly to people of color as maybe it should have been.
Thank you, Owen. Dr. Toya.
So I work predominantly in clinical medicine, so I see patients every day, pretty much. And I'm fortunate that I am able to work in both a private practice setting in an urban area with non-Native patients, and also work on a reservation with predominantly Native American families. And I describe it, the differences between the two. It's like most of America lives in a bubble. And when this started in March of 2020, what I saw was most Native communities really took attention. This was scary for us because we knew 500 years of colonization that we were in trouble. And I'm so proud of our communities, because a lot of tribal governments here in New Mexico stepped up and started doing social distancing and mandating masks and closing some of the borders to the reservations 6 months before the rest of the state did. And I think one of the things that I try to admit, I guess, with my families and my patients is I try to avoid something that I called the culture of despair, which is with all these negative data points and deaths and morbidity, mortality, it really can drag us down as communities of color. And so what I try to do, and I used to do research a while ago, is how do we turn this horrible environment that we have right now, but how do we focus on some of the positives? Native American people, when the colonizers landed 500 years ago, the estimates are 90% of North and South America's indigenous people were killed by infectious disease before even physical contact took place. Smallpox and measles and all of that spread across these continents. So we're survivors, we survived that. And that's what I try to tell Native families, indigenous people, is we're gonna be okay. We're gonna get through this. It's gonna be difficult, and it has been. It has been. I'm not a big believer in sharing a lot of negative data, but I think it is important. And I'm going to share one piece of data that I think really illustrates how Native American people have suffered from this epidemic, even with the best planning, even with people knowing that it was going to affect our communities. We have 22 reservations in New Mexico, each is their own sovereign government. So just one fact. So if Native American tribes were counted as states, the 7 most COVID-19 infected states in this country would all be Native American tribes. 4 of them are in New Mexico. And this is astounding. This is a number of cases per 100,000 people. More of those deaths are in younger people, less than 64. In New Mexico, where we make up 9 to 10% of the population, 57% of the total COVID cases are Native American. 32% of the total deaths are Native. So those are the negative statistics. Those are the things that we hear, that culture of despair. But when I talk to families and I'm in the exam room and they're scared, and they do have people dying, whole families are dying on the reservations, and we won't know this data. We won't know exactly how this has affected our communities for a couple of years, because again, as Dr. Garrick was saying, our people, our groups aren't, the data is not there yet. And this brings me to what I do, what my main focus is. We know that we're an at-risk population. Why is that? We suffer from high rates of diabetes, hypertension, obesity. We know that. And you know, our Indian Health Service is chronically underfunded, and we have tribally run community clinics now too, and that brings up a whole another set of issues. But we need more representation from people of color in our jobs. And you mentioned it, Ben. There are very few Native American doctors, very few Native nurses. And that's what I'm really trying to push, is trying to get our people in those positions where we can make changes, can decide to be part of a drug study, which we need to be part of. And that's just been my underlying goal for years, is trying to get underrepresented minorities into these fields. How are we going to fix that right now with COVID? We're not. Right now, we're trying to get I just got my vaccine, everybody, yesterday. So that's another issue, is, you know, how do we gain the trust back, Dr. Garrick? Is there isn't a lot of trust with Native communities and physicians and research. There isn't a lot of trust in the vaccine right now, which surprises me, because we are one of the most heavily vaccinated populations in this country. And all of a sudden, and I think it's because of social media, people are really worried about the vaccine. And I spent, again, in the clinic room, I try to tell people this, it's going to be okay. We're going to be fine. Let's get the vaccine. But again, we need more people like us out there saying it's okay, let's do it. So it's an ongoing battle, but it's something that I'm invested in.
There's a great amount of courage and fortitude in the story you just told. And there are several themes that I'm sensing overlap here. I see Dr. Pernell nodding her head. I'm wondering, when it comes to outreach, community, and trust, whether Newark in New Mexico, there are some great shared lessons there. And Owen, what you talked about in terms of representation is also a recurrent theme here in the actual trials that we're conducting and the actual conversations we're having in leadership. Don't go far from your Zoom square, Yolandra, because I'm going to come back to you in a second. But I do want to acknowledge some of these recurrent themes, and I'll try to thread us back to them. But community engagement, trust, and so on do come up. I will say, I'd be remiss if I didn't. We also need to look at how a lot of what you're talking about starts at home. For us right now, home is Princeton, my virtual backdrop. And there was an important announcement made just in the last couple of weeks of a endowed professorship on Indigenous studies from Wendy and Eric Schmidt, really Wendy Schmidt being a driving force behind this. And its remit is to look at Indigenous peoples globally. And we have to start somewhere. And I think that it's an important step for the educational mission here at Princeton. We also saw a nomination, a first ever, from the transition team of a Department of Interior secretary who's Native American. So again, steps that are being taken, but I don't mean to digress. Yolanda, I said don't go far from your Zoom square, because I want to actually pick up on the last note, and that is federal partnerships and cooperation. We all have, you shared some important data points. I said how at the beginning of this data is going to be important, as well as stories. Some data points about these statistical gaps and how there's a lack of information being exchanged between tribal epidemiology centers and federal agencies. You talked about funding. Are there solutions at hand on enhancing partnerships at the federal level? What is your view on that, if you would share?
Well, I think the interesting thing that happened this year, and it wasn't unexpected, is that there has not been a focus on the federal relationship with tribes. That was missing in the last 4 years. We were sort of forgotten. And we knew that, you know, and this is not our first rodeo. We've been through many, many different presidencies and different Republicans, Democrats, whatever. And again, I always bring back, we're gonna get through this 4 years. But we were ignored and still are ignored, I think. There is supposed to be a relationship between the feds and the tribes. We're the only politically defined minority with trusts and treaties with the US government. We're supposed to be afforded health care in these treaties. Of course, we all know that that did not happen. So what is interesting is this year we were almost forced, but in a good way. I mean, I'm always trying to look at the positive side. We were forced to really work with local and state governments, which is actually not really how we were supposed to be run. And so I do have to say that with our current governor, New Mexico governor, she really reached out to the tribes and helped in many ways. So I think that was really a good thing for tribes to sort of realize that that one relationship with the federal government is not guaranteed, depending on who's in the White House. It didn't help that we had a president who disparaged Native American women by calling them Pocahontas. And I just don't get that. But that being said, that 500 years of resilience, we're gonna get through this. The work with the states has been very helpful. When COVID came out, tribes actually had a choice to either get their vaccines from the Indian Health Service or through the states. And some tribes chose the states. The problem is we did not get very many COVID vaccines. For our small communities of 2,800 to 3,000 people, we got 55 doses to 65 doses. So that was barely enough to vaccinate the clinic staff. I think this was a wake-up call for tribal communities that we have to be, again, resilient, but we have to really sort of think outside the box. And this is what my favorite sayings is, think outside the res box, because we're not just sitting there on the reservations. We have people that go back and forth. We have families that live on the reservation, off the reservation. So I'm looking at it as a way that our tribal communities can actually think of different ways to take on their own health care. We still hold the federal government accountable, of course, but we have to train our own. We have to think outside the box. We have to be part of those vaccine trials. We have to be, you know, people think that Indian Health Service is an insurance plan, and it's not. And Native American people by far are the biggest group that are not insured in this country. And again, this is us sort of thinking outside the box and how can we fix that? And again, this is why COVID affected us so horribly, is because all of those things were the perfect storm. As Dr. Pernell was saying, we were set up. This has been going on for a while. That first epidemic never stopped, and it won't stop. Even after COVID is done, hopefully, with the vaccine, how does it fix our problems? How do we get ready for the next pandemic?
You're doing my job for me, because we're gonna pick up on that thread in a second, and that is what comes after COVID. What here returns to the margins of our consciousness as a nation and what stays at the center. Before I do that, though, I want to let the audience know that we will have a Q&A period for you to engage with the speakers as best we can through this environment. So you should have a Q&A button at the bottom of your Zoom screen. If you're on Facebook Live, I apologize, get over to Zoom if you want to ask a question, and I'll keep an eye on those. But for now, let me turn to Chris and Owen, and let's pick up on some topics that Owen, you touched on, and Yolandra, and that is trust in the community, specifically trust in the Black community when it comes to vaccine use. It's not specific to that community, but there's historical antecedents. Would love for each of you, maybe starting with Chris, to talk a little bit about how you're addressing that.
Sure. I've been living in this conversation, right? This is the bulk of the conversation that I'm having on a daily basis. When I lost my father, I explained that my father was a research scientist. When I lost my father, when I saw how devastating the pandemic was in my family, so at this point, my father I lost and my sister was also infected and struggling. When I looked at my safety net hospital here in Newark, New Jersey, I saw us bursting at the seams with Black and Brown patients. Yes, we serve a Black and Brown majority community, but I saw nearly every bed filled with a coronavirus patient and a very sick coronavirus patient. I saw data, and I think it is important to drill down in data, even when that data is negative, because too often in our American society, there is a culture of ambivalence, there is a culture of ignorance, and a culture of apathy. I've been involved in health equity, and there are decades worth of healthcare disparities research, but we never have galvanized the public's attention like we have now. And I'm hopeful that as an outcome of this, that racial justice, racial equity, health justice stays at the center of the dialogue like it deserves to do. And so going back to that story, that narrative of losing my dad, having a sister who was a lone caller, being at work, and the majority of our patients being very sick, having our emergency medical services team have a 200% spike in DOA runs, dead on arrival runs, meaning finding people dead at home. And not necessarily dead from coronavirus, but dead from a host of contributing factors because of fear and a paralysis that overtook this region when we were very much the epicenter of that pandemic. And I needed a way, and you speak of resilience. Resilience has to be built in systems first before it can be built in individuals, because systems have this power that oftentimes trample on individuals. But I needed a way to operate in resilience while practicing vigilance. And so I enrolled in a coronavirus vaccine trial myself. And when I did that, the center of that conversation was often, why are you doing that? You know, you're going to be a guinea pig. I needed a way to be a part of the solution. And I very well understood that if Blacks and Browns don't participate in clinical research, it perpetuates the inequities that we're saddled with, right? We aren't able to say in an informed, conclusive way whether or not interventions, whether they are therapeutics or prevention tools, are generalizable. And it's not because of biology. I'm not talking about, race-based medicine. We need to do away with that fallacy. I'm talking about people in the conditions and environments in which they live, work, breathe, and play, and whether or not those therapeutics or prevention tools will be effective given their environments. So we went immediately into community here in Newark, New Jersey, to have that conversation about getting their participation in the coronavirus vaccine trials. We sponsored one right here at my hospital in conjunction with Rutgers, New Jersey Medical School. It is because of the enslaved Black women who were subjected to gynecological surgeries by Dr. Sims without anesthesia and without their consent. It is because of Tuskegee, Black men infected with syphilis knowingly having treatment withheld. It is because of Henrietta Lacks, a Black Baltimorean in the segregated Maryland who had metastatic cervical cancer and had tissue samples taken from her womb without her consent, and without her knowledge and her knowing of her family, that have gone on to become one of the most productive cell lines. It is because of things like Mississippi appendectomies, Black and Brown women being subjected to forced sterilization under some other guise, even Black bodies being robbed from cemeteries, right, in the post-Civil War era, to help medical students learn anatomy and dissection. It is because of those historical traumatic events that I faced the skepticism in community that I did when I first started this conversation around participation in the coronavirus vaccine trials. And it's not only because of the past, but because of what we see today. Ongoing disparities, whether it is implicit bias, how that interferes with provider-patient interactions, whether it's a difference in treatment recommendations for certain groups, studies done recently with medical students and trainees and saying, oh, Black people sense pain differently because the thickness of their skin is different. those type of lingering beliefs. And when we as a community can see that and have experienced that collective trauma and burden on our psyche, how do we deal with that knowing and still deal with the request that's put before us? So we were looking for a way to have this conversation through a very empowered model, meaning your lived experience is your power, your history is your power. I see you, I hear you, I respect you, and I approach you with humility, I approach you with transparency, and I approach you with empathy. And we elevate the voices of those who are trusted or who have value in your community, but at the same time as elevating the voices of those who are trusted and have value in communities of color, we in the academic medical complex, we in healthcare and public health more broadly have to demonstrate trustworthiness. We have to bring trustworthiness to the table. And trust is not going to be built overnight, but trust can be cultivated through a series of actions that says to community, your priorities matter. You have a seat at the table in setting, whether it's research agendas, you have a seat at a table, whether it is in setting of services and resources and assets, an asset informed, asset mapping approach to how we do population health and community health. And so we're very much still having those conversations that we had around corona vaccine trial participation, around corona vaccine acceptance or willingness. And we're having it with health workers this time. I'm spending my days rounding the hospital, talking to the transporters, talking to the EVS workers, talking to the food and nutrition workers, talking to the nurses on our COVID unit who say, I don't want the vaccine, right? To make sure we can begin to decipher through the skepticism, through the broken trust, and meet that with factual information, meet that with storytelling, and know that this is going to be a process and not an overnight solution.
Owen, if I could, before you start, I just want to do a couple of things. And one is throw out the questions I've got in my hand, because our audience is smarter than I am. And I want to acknowledge Tyrone Woods, who has written, and Chris is sort of dovetailing with what you talked about. Tyrone Woods says, trust is the biggest issue regarding receiving the vaccine. We as a Black community need to see this to be effective and safe and not think of this as the Tuskegee experiment. Conrad Pearson, I hope I pronounced your name correctly. Conrad says, it was a question, which I think in large part, Chris, you've answered. Owen, I'll also toss to you. It seems that the process of public communication, education, and persuasion has been limited and disjointed. How does the panel think the process can be improved? Chris, you just sort of laid out a roadmap. Owen, I know there's a lot of questions in that, but I toss to you next.
Sure. So this notion of trust, right? I've been Black all my life, right? And these issues around our engagement with the healthcare system are not new, right? So this notion that I'm not going to try to convince Black and brown folks that, you should be taking this vaccine because all of a sudden, it's the right thing to do, right? I think, and we generally don't try to convince folks that they should do or should not do something. Our goal is present in a fair way what we understand the benefits and risks to be. And I think when you do that, people make, good and informed decisions, right? So, and there was a question, and I forget which of the two individuals you mentioned, Ben, asked about, the communication seems to be disjointed. And I agree, right? And, the things that on what I'll call the positive end that are missing, right? So if we think about the virus that is causing the disease, right? SARS-CoV-2 stands for, the SARS part is severe acute respiratory distress, COVID coronavirus. The number 2 is the number 2, which suggests there was a number 1, right? And the number 1 was SARS-CoV-1, was the SARS we all remember from 2003 or so, right? So there's been a ton of research on the coronavirus since then, right? And since then, what we have learned, right, it's not just the genetic makeup, but we learned and scientists, not me in particular, but uncovered the fact that the ACE2 receptor in the human body is the primary target. We uncovered the spike protein that we all hear about now. So there's been a ton of research in almost 2 decades that's been going on, which I think has led to, in part, this advancement that we all sort of see coming out of the sky in the last 9-10 months. And the fact that, frankly, money has been no object has really added to this, right? So a lot of that good stuff is really missing from the conversation. On the flip side, right, I think when we hear that, you know, the vaccine from the trials are 95, 96% effective, that's frankly a little misleading. It is factually true, right? But what most of us think is when we hear that number, 95% of us will go about our usual lives. We'll go to football games, we'll be in the subway, we'll be in crowded places, we'll be coughing and carrying on. And 95% of us won't get infected or won't get corona. Now that might be the case, right? But in the context and of the study, right, the 95% number, the math is literally less than 200 individuals, right? Individuals that showed symptoms, right, from the disease and were shown to have be infected versus all those that may not have been symptomatic. So, the point is, folks see this, right, and kind of, don't quite trust it. And I think it just takes some time to explain that, no, there's a lot of great science that went into this. And yes, there are some things that we did that we would not normally do, right? You would go about in your normal lives for 2, 3, 4 years and see if individuals got infected. And we just literally do not have the time to do that. Right? And just be open and honest about that. And I think that open and honest conversation, gets people to think, okay, I get it. And they begin to make better decisions, right? And now that takes some time. And you have to balance that. I think, Yolandra, you mentioned earlier on, what people hear on social media, right? So that's going to be part of the challenge. The other part of the challenge is when you go from 20 or 30,000 people that were in a study to 2 million and 20 million and 200 million, you're going to start seeing more of these side effects, right? Because even if they're at the same low percentages, you're just going to see more of them. And so we have to figure out how to effectively communicate that, yeah, these side effects are happening. We expected them to happen, but also I think Chris's point, the stories of all the individuals that are being positively impacted, not by just vaccines, but all the therapies that still exist. So part of that communication, or a lot of that communication, I think we have not had in the last 9-10 months. We've been arguing about whether or not we should wear masks and people not wearing masks, and just having this disjointed communication from the tops of our federal and state and health leadership.
Can I just say one thing really quickly to add to what Owen said? In like when I'm speaking with worker groups or in community, to differentiate a side effect from a serious medical event or from an adverse event. Side effects are to be expected. It means the immune system is working. The side effects that were described in the study and that I experienced myself without knowing whether I was in the placebo arm or the vaccine arm, the headaches, the fatigue, at times the congestion, and helping people to know what to expect. I think we must do a better job around in demystifying that for people. We must do a better job around.
I'm going to pin that idea of demystifying. I want to acknowledge it was Conrad Person that asked the earlier question about trust in communications. And I want to give a shout out to Sarah Afif, if I pronounced her name correctly, who asked, how are people of color receiving information and making decisions about their health during this pandemic when there is a lack of trust in the healthcare system? And those that provided, Owen and Chris, I think you both went a long way to address that. Yolandra, I'm gonna turn to you for the next question. And again, we're getting really strong questions in the Q&A, so I'll try to get to all of them. This one is a question and a hello to you from Nancy Lynn, class of 77, who says hello and asks, can you suggest specific activities and programs that we can support to improve the healthcare situation for Native Americans? And if I can also say hi to Nancy and then expand a bit, there is this element, you talked about bubbles. We're seeing how so much of our lives are interconnected, while the health of individual communities is important for me to tend to. So if Nancy doesn't mind, I'm going to embellish a little bit. How can we support the healthcare situation for Native Americans? And why is it important for us here in New Jersey?
So I think there's two things that we can do. I think I always tell people that I think Native Americans are the forgotten minority of this country. And just to bring up two things that happened recently is I was so happy when we got rid of the Washington Redskins and the Cleveland Indians stereotype logo, whatever it is. People still see us in that way as a historical relic. And a lot is being said here that I think we could have this conversation for another 5 hours. But if people can actually talk about this country in its diverse form that it is, it's not we're just all Americans. We're an amazing country of different people from all different kinds of, places and ethnicities and race, socioeconomic. If we can just be open and talk about, well, how do vaccines affect Native Americans living in New Mexico? How do they affect people living in Oakland? How do they affect Hispanic people in Texas? That we need to talk about that. It's not one size fits all. And that's what makes it interesting. People see that talking about diversity breaks us down. I don't see that. I think we got to open our minds. We have to talk about Natives and his different kind. There's not just one Hispanic, there's Mexican Americans, there's Cuban Americans. That makes it interesting. And that's what makes medicine to me interesting. Specifically, I think if people want to help nationally, I always look towards the National Congress of American Indians. So there's a national group that talks about policies and laws and the big focus on Native Americans in general. Specifically, I'm really impressed with what people are doing at Johns Hopkins University. They have a Center for American Indian Health there. A good friend of mine, Allison Barlow, is the director. In Baltimore, they actually have programs here. In Arizona and New Mexico, they actually are looking at vaccines, COVID vaccines, and on Navajo Nation. I think that's amazing. And if people want to help and on that level, that would be a great program to support. I was involved a little bit when they developed a coloring book for Navajo Native American children to think about COVID. And I think that's what a big missing piece of this is. How is this affecting our children? I mean, my God, another separate issue that we could talk about. The number of teenagers that I have put on antidepressants and antipsychotics in the last 6 months. I'm not a psychiatrist, but here I am. I have to do this. We have to address this. This whole school year should be a do-over because I don't think any of our children have really learned anything. And that brings up another issue that most of our tribes don't have those basic utilities that the rest of us in the bubble take for granted, like internet, like cell service, like having a computer, like having a phone. So a lot of these children are being left out literally in the cold. I mean, 30% of Navajo Nation does not have running water. So those are the very basic things that we're dealing with. Those are the two programs that I would, if you want to help at that level, that's what I would do. People can email me and call me too if there's specifically, something very specific that they want to do. Email me.
I will put our colleagues on the spot a little bit here, and we'll figure out a way to continue this conversation, whether it's by email follow up or some such a mechanism. Because Yolanda, the points you raise, Chris, Owen, the others, there may be some interest in that. And again, judging by the questions, for example, I want to acknowledge Jessica Gadsons, who just asked about, frankly, another forgotten population, that is the prison population in America that is being affected severely. I'll just read from her question, but then get to a second one. Jessica writes that it's been shown that 1 in every 5 state and federal prisoners in the U.S. have tested positive for COVID, 4 times the rate of the general population. How do we support healthcare for this vulnerable population? But I also want to turn to an anonymous attendee who asked, and speaks, I think, on behalf of all the students we have on right now, Princeton or otherwise. Tuning in is one thing to a conversation like this, having our minds open to these stories, but how can we actively battle these health inequities in marginalized communities. And I'll open the floor to anyone who wants to jump in there, but I do want to note one thing, and Professor Heather Howard did reach out to us before this, Heather Howard is from our School of Public and International Affairs, SPIA, and Director of State Health and Value Strategies. She noted that a number, there's a thing called the 250th Anniversary Fund for Innovation in Undergraduate Education. A special cycle was instituted this summer to develop courses that address systemic racism, racial injustice, and so on. And then a parallel set was to develop courses with a research focus addressing COVID-19. And Heather's students, and I hope I'm getting this right, did research on vulnerable populations during COVID and presented to the New Jersey Department of Health. Among the populations they focused on was New Jersey prisons, as well as nursing home residents in congregate care settings, and also migrant farm workers living in dormitories, these populations that often go overlooked. So a shout out to Heather Howard and her students who participated in this research and continue to look at creating resilient healthcare safety nets and trust in communities. So that work is starting, is underway, I should say, in the Princeton community and elsewhere. So I'll stop there. Chris, Owen, Yolanda, do any of you want to pick up on what students could do more to be involved in this effort?
Sure. I'll weigh in quickly. So since I'm a health equity doc, a lot of my work focuses on the conditions or the environments that predispose people to certain exposures, right? And those exposures carry inherent vulnerabilities. So what we're thinking through, and what I would encourage or challenge our students to begin to think through, are what are some of those conditions. For instance, what we're looking at is housing, right? We're looking at opportunities where anchor institutions, healthcare institutions can partner, whether with local municipalities or with state-based agencies, to create stable housing opportunities, right? Because there are vulnerabilities that inherit in whether or not you have access to adequate housing stock. So learn about housing. Housing is healthcare. Learn about whether it is rental assistance programs, or whether it is these novel and innovation projects. We're participating in one here in Newark, New Jersey with our HMFA out of the state, looking to develop supportive housing units. And no, you as a student couldn't necessarily do that, but you could learn about it and then begin to practice advocacy. I did my Prev Med and for public health training at Johns Hopkins. And what we are articulating now in a very clear and compelling tone and narrative is public health advocacy. And students can get involved in public health advocacy right now. You can get involved in public health advocacy at the local level. So the communities in and around where you are living right now, and if you're not on campus, the communities in and around campus, you can get involved with public health advocacy groups, joining APHA, and seeing how to do advocacy. That really matters. I once was telling my peers back when I was in my training, we need to be political physicians. And I'm not talking about big P running for public office, but being involved in policy and being involved in where action is happening, the decisions and the choices that are being made. So as a student, get informed, get engaged, and start working on public health advocacy, because that's what we need to work around these larger structural issues that determine exposure. And I'll leave it there.
I don't know if the panelists realize this, but I'll tell them now that by agreeing to do this panel, you've also offered to help these students do their research. So we'll follow up. I say with a nudge and wink, because Heather—
Become a public health physician. I got to toot that horn. Become a preventive medicine and public health physician. Very few people have ever heard of the term, even in medical school. So we need more public health and preventive medicine physicians, and especially more public health and preventive medicine physicians who look like the communities that are saddled with these disproportionate burdens.
Yes.
Realizing that we are at time, I'm going to toss to Yolandra, because guess what, everyone? She has to go back to the clinic to continue her hard and good work. So Yolandra, quick closing note for you, and then I'll turn to the rest of the panel. And for those who can stay on this this event, please do.
So big shout out to public health and medicine, because I did public health for 10 years before I went back to medical school, and I was an outcast in medical school. Nobody understood it. So I just want to briefly, Ben, you mentioned the new endowed professorship of Indigenous Studies at Princeton. I do have to plug in that I was part of the Native American alumni group that recently formed in the last year. It's never been an alumni association of natives at Princeton. There's about 40 of us. That was one of our original ideas. And we pushed that because unfortunately, Princeton has not really responded to a lot of Native American endeavors, not very many students, no faculty, although we do have a faculty member now in the English department. So when we put forth that chair, we specifically said that we want this chair to also push ideas besides history and religion and culture, which we're always pushed into that, right? Because, you know, that's just what people think about Native Americans. But we wanted this chair to also focus on policy, on law, on health care, on public health, inequities. And that was really big for us because we can't be seen in the historical context anymore. This is a problem. And they listened. So we were pretty excited about that. And we were not publicly acknowledged about, you know, helping to bring people together to the table, but I'm very proud of our group for doing that. So that being said, what can students do is, just like Dr. Pernell said, is really to try to look at these communities that need some help. I would love for somebody in the engineering department to take on, how do we get running water to these rural areas on the reservation? How do we get internet service for every Native American child who lives on the reservation so they can do their schoolwork? How do we solve those problems? That would be amazing. So if students want to do that, that's great. And it's hard to do research on the reservation, that's true. But there are people like in our alumni group, I think, who would be very helpful in being mentors to these students.
Yolanda, thank you for that. I have a feeling this will result in many follow-up conversations. Let me work back around the horn then. Over to you, Owen, for some closing thoughts. The things that you mentioned in particular were, for me, what we take for granted and what we can't anymore, whether it's during COVID or life after COVID. But over to you, sir.
You know, I'll just be brief, right? Because I know we're over time, but the things I think about is, as we think, and the reason we do research is, let's try to find some unique solutions to problems and figure out how we scale them, right? So getting back to the student question, right? You know, the students, you know, Chris and Yolanda and I are often in like committee meetings and, you know, in our office, and the students are the ones that interact, I think, and are on the ground and have a clearer sense or more updated sense of the real issues that are happening in the community, right? So, you know, and I mentioned research questions earlier, you know, they can help us think through what are the real challenges that are happening in the community, help us, you know, think through research questions, help us do the research, and then begin to think about how we, you know, with positive findings, scale those some of those findings into the broader community, so begin to disseminate it. So those are some of the things, you know, I think about on a day-to-day basis. It is always great to see some good folks that look like me. And a just quick shout out to Yolanda. She was one of the senior pre-meds when I was running around campus. So even though she wasn't a formal mentor of mine, you know, she really did, you know, her and many others like her set the stage for us, right? And so that, and I'm sure Chris can talk about the same thing, right? We've all had mentors that have really added value to our careers. And I had to practice saying Yolandra because we just called her Yoli all the time. So
you can still call me Yoli, it's okay.
So, you know, folks like that are really, really a true treasure.
Wonderful. Chris.
I will start with a word to the students to continue to get in good and necessary trouble, because I think that's what's needed to at times shock us out of our complacency, to dare us to progress and to demand transformation. I am hopeful that we are at a point, and this is to Yolandra's points and even Owen's points, that we don't regress where we're fighting for the public's attention or the infrastructure necessary to answer these persistent health equity issues, that this becomes a larger and a larger lens around not just the coronavirus pandemic, but around those conditions that make life outcomes more problematic for certain groups. And I'm hopeful that students can lead us in a lot of that because of their immediacy to these issues. And I would say that though the winter is projected to be dark, meaning that we will continue, unfortunately, to have a death toll that rises, though we will continue to see increasing hospitalizations. We are definitely not without hope. And I'm looking for an opportunity for there to be a singular and unifying message across all levels of government, across all sectors and industries, that we can practice empathy and science at the same time, that we can speak truth to power, we can speak science to power. We can say things like white supremacy has too often used science as a tool, and to begin to deconstruct that so communities can have access to the power of science and the benefit of science, whether that's public health science or biological sciences. And so I'm encouraged by dialogues such as these because they spur action, they spur hope, and they spur that good and necessary trouble. So definitely let's look to make health equity the staple of all of our interactions and not just that thing we talk about when a crisis emerges.
Brilliant. Chris.
And Chris and Owen, I'm going to have to go, but it was such a pleasure. Thank you for letting me on this panel. Thank you so much. But continue the discussion. I look forward to hearing from you guys.
Thank you.
Okay, bye.
So I think Yolanda just committed us to a part 2. So Sean, Shante, others will note that. But look, there were several other questions. I want to acknowledge Lisa Haynes, Brigid Dwyer, a dear colleague, and others. We like I said, hopefully we'll continue this in different fora. I want to just repeat something that Owen, I think you said about mentorship and acknowledging Yolandra. That in my time at Princeton has been something that's been a wonder to behold, is the giving it forward, giving it back, whatever direction that is part of clearly a Princeton ethos and where I went to school at Georgetown. The motto is truly lived in the nation's service and service of humanity. You all have embodied that. So thank you for your time. And when it comes to dialogues like this, I'm going to invoke one of my favorite analysts of racial relations, Jimmy O. Yang, who says representation matters. And I know that was a theme that you all touched on as well. So we are dedicated at the Office of Communications in partnership with colleagues like the Office of Institutional Equity and Diversity to do more programming like this. Thank you for your time and your insights. Thank all of you in the audience for your questions and engagement. And we wish you the best, especially as we look towards the new year. Sean, back to you.
I think we're good to go. So we'll see everyone next time. Thank you all. Take care. Bye-bye.
Thank you.
Bye-bye.